Good afternoon. Welcome to today's Tuesday topics. And today I'm going to talk about very quickly and really succinctly how we're going to use ScvO2 and why it is so incredibly important to us when we're evaluating and caring for our patients. So I'm going to go ahead and share my screen and get started with the talk. And I'm so grateful that you all made time in your busy day to be with me today. So, why and how do we use ScvO2? ScvO2 actually requires that you have a central line and that central line either ends right at the junction of the vena cava and the right atria, but most optimally, the catheter is actually well into the right atria. We can draw a blood gas as a sample from that central line. We draw it from the distal lumen, that's the brown lumen, and we send it off to the blood gas lab to look at the saturation of hemoglobin in that venous blood. Normally, we expect that to be greater than 70%. And along with that, we can look at only at the central venous PO2, which is normally 35 to 45. Now, let's just think about that as we compare it to arterial sat 95 to 100, arterial dissolved oxygen, PaO2, 80 to 100, it's significantly lower when we're looking at blood that returns through the central vein to the right atria. And of course, we always have the opportunity as well to look at central venous pressure, which normally is about 1 to 9, could be -4, could be 15, but the range is 1 to 9. Now, just quickly, oops, sorry about that. Quickly taking a look, you can see the tip of the catheter is right here in the right atria. This is the optimal position. If you've done a central venous catheter from the left subclavian, it won't quite be in the optimal position. It'll be at the caval junction, which is okay, but always better if we can get a catheter that is placed down into the right atrium, which is one of the reasons we always try to use the right side, either for subclavian or jugular, but really subclavian is where we're going to thread our central venous catheter. How lovely is that? Because it'll leave the IJ open for your vas cath should you need to do renal replacement therapy. Now, just like you draw a blood gas from the artery, you're going to draw a blood gas from the central venous lumen, the brown lumen, the most distal from you, to actually send to the blood gas lab. And you can monitor this continuously with a special catheter, or you can do intermittent blood draws and send them off to the blood gas lab, or do point of care if you have an ISTAT capability. Now, what's really important here is to talk about people use these terms interchangeably. They're not interchangeable. SvO2 is the saturation of the mixture of all venous blood that returned to the right atrium, the right ventricle, and was ejected up into the pulmonary artery. So it is a global representation of every area in the human body that consumes oxygen, averaged together. ScvO2 really only reflects the remaining oxygen in the blood that's returned from the head and the upper extremities. Remember, it's measured in the superior vena cava. So because it's in the superior vena cava, it's not integrating everything that came from the IVC or anything that came from the carotid sinus and the I'm sorry, not the carotid sinus, the coronary sinus and the coronary veins. So ScvO2 really tells us about the brain and the upper extremity. Now, that's really important because when you have poor oxygen delivery to the rest of the body, you will shunt blood to the brain. And if that ScvO2, which is reflecting the remaining blood, is low, that's telling you that you generally didn't have enough delivery of oxygen to the brain to maintain its normal function. That's why this is so important. And I think you're hearing more and more and more. I just spoke at a trauma conference in Northeast Georgia, and I'm talking about ScvO2 and base deficit and the importance of CVP and systolic pressure. I couldn't believe it. Everyone was talking about it, plus POCUS, point of care ultrasound. but everybody is talking about the utilization of ScvO2 when you have a central line. That means we need to raise our bar in terms of how we're understanding this, how we're applying it, and how we put that into a clinical picture. So I talk about this a lot. And so if you've heard me before, you've probably seen some of these slides, not all of them, but some of them. It is really important to remember the single most factor, and it's insidious because it has really nothing to do with heart rate, respiratory rate, and blood pressure, all of which may be misleading. Blood pressure, worst of all, being misleading in the resuscitation of patients. This is the single most important issue in acute and critical care for resuscitation, is whether or not you have adequate tissue oxygenation. So everything physiologically is designed to keep a balance between the delivery of oxygen to the cell and the cell's consumption of oxygen. Delivery of oxygen to the cell and the cell's consumption of oxygen. So when we think about maintaining normal cellular metabolism and cellular function, we separate this and we talk about what delivers oxygen. Well, of course, cardiac output. Your blood flow delivers oxygen because your blood flow is what's carrying hemoglobin. Your hemoglobin is what's carrying oxygen. So you've got to have blood flow, and typically we're going to talk about that as cardiac output. You have to have hemoglobin. We talk about that as hemoglobin, and your hemoglobin must be saturated. And we talk about that as SaO2. Now that blood may be fantastic on the arterial side. You have a great cardiac output, you have adequate hemoglobin, you have a good arterial sat, but that is all pre-cellular, my friends, pre-cellular. You have to know what's happening at the global cell. When I say the global cell, I mean the total body tissue. What are the cells demanding? And what are they using? Now, in order for us to understand that, we're going to use some simple things. Anion gap. Why the anion gap? Not specific, but a good cue. Bicarb, total serum CO2 on your venous profile, or maybe in your hospital, you call it bicarb on your venous gas, on your venous sample, your chemistry. So you can do anion gap and a bicarb on your chemistry. You can do a special order that would be lactate. You could do a special order for ketones. You can use a blood gas to tell you about the base, which, remember, when base goes down or base is in deficit, metabolic acid is always up, and that's a metabolic problem. That's a cellular problem. And you can add ScvO2. So quite clearly for me, I love heart rate, respiratory rate, blood pressure. And I don't love blood pressure very much, but most of you are in love with blood pressure. You'll never divorce yourself, and that's okay. It's all cool. But I'm really much more about stroke volume, heart rate, hemoglobin saturation, stroke volume times heart rate being cardiac output. And then looking at base, bicarb, anion gap, and ScvO2. Now I can add in lactate and I can add in ketones, and all of those are good. The more information, the better. But what I always want to look at is the balance between the delivery of oxygen to the cell and the utilization of oxygen at the cell. Now, the utilization of oxygen at the cell is going to be expressed to me, most particularly when my cells are anaerobic or hypermetabolic through the production of lactate. But also when my cells are hyperdemanding and they are able to consume oxygen, I best evaluate that by ScvO2. ScvO2 says how much oxygen remains after a normal run through of blood through the capillaries. Anytime your ScvO2 is less than 70%, and even more so, if it's less than 60%, you have a patient at risk. Do something. Write that number down, but don't just write that number down and go on your little merry way. You need to communicate to your team. You need to say ScvO2 is low. You should always know when you call them what's your anion gap or your bicarb or your base or your lactate. You need more information. Can't just be ScvO2. And if they choose not to treat, you need to make sure you documented that you've notified somebody that the ScvO2 is low and there are signs of metabolic acidosis. Otherwise, it just looks like no one knows what they're doing at the bedside, especially when we're documenting numbers that are unacceptable, that are indicators to us that we have a patient who is about to fail. So I always like to use this little dynamic to say oxygen delivery is the combination of cardiac output, which the patient himself manipulates quickly, and we manipulate when we give them volume or we give them inotrope. Hemoglobin, which the patient has a constant level of hemoglobin. If he's lost his hemoglobin, we're going to give him blood, and his arterial saturation. Now remember, these are arterial side dynamics. That means pre-cell. At the cell, oxygen is consumed, and oxygen is either adequate or it's not. If the oxygen at the cellular level is not adequate, the first thing you're going to see is a base deficit and a decrease in serum bicarb. Those are real time right now. Lactate takes a minute to elevate, so it's not the greatest thing in an emergency. Really, base bicarb, total serum CO2, which is bicarb, or your anion gap are going to be really more meaningful. But the most meaningful thing is, in this case, ScvO2. ScvO2 tells me whether the cells, in order to maintain their normal consumption, had to dive into the venous reservoir of oxygen in order to sustain themselves. Now, we're going to call that oxyhemoglobin dissociation. Don't get worried about a bunch of syllables. These are just a bunch of syllables. All it says is, why does hemoglobin release oxygen? Well, hemoglobin releases oxygen because the cells need it, and the hemoglobin releases it so it can dissolve in the blood, because it has to be dissolved in the blood. That's what exerts partial pressure in order for it to move to the cell. So hemoglobin releases oxygen to dissolve in the blood to be used by the cell. And when our ScvO2 is dropping, that always, always, always tells you that your delivery is not adequate for whatever the demand is. So your goal will be, how can I decrease the demand? Or are they hyperthermic? Let me get them cool. Are they agitated? Let me get them calm. But also, how do I deliver more oxygen? And the best way is to manipulate cardiac output, volume, and inotrope. If necessary, give red cells. As long as your SAT is greater than 88 or 90%, increasing your SAT isn't going to improve things very much. So really important. Okay, I wanted that to really be a good visual. So keep your eyes wide. Really important to understand that oxygen consumption is referred by ScvO2. So whenever ScvO2 goes below 70, and in a clinical environment, you're going to probably say below 65, your cells are consuming more oxygen than is being delivered adequately. They now have delved into their reserve, and now they're severely at risk. So when we think about oxygen delivery, remember that's arterial side dynamic. That's cardiac output, which is heart rate times stroke volume. Normal heart rate, 80 to 100. Guess what? Normal stroke volume, 80 to 100. Okay, so when I see someone who's tachycardic, I'm already saying, what are they doing and why are they increasing their heart rate? Because they're trying to increase their cardiac output, which typically means their stroke volume is inadequate. So then I'm going to give them volume, and then I'm going to reevaluate them, and I'm going to use endpoints for evaluation of volume resuscitation. That's not what we're talking about today. And then I'm going to look at their total hemoglobin, remembering that hemoglobin is the only purpose for hemoglobin is to carry oxygen. And then I'm going to look at the saturation thereof. Now, the first line compensation for a patient in trauma, cardiac shock, hemorrhagic shock, septic shock, first line compensation is to increase the heart rate. As they increase the heart rate, they may also attempt to increase the stroke volume, but they've got to have volume, and they have a good heart in order to do that. So the first thing they do is increase that heart rate, try to increase the stroke volume. We try to increase their stroke volume in order to increase delivery of oxygen to the cells that are hypermetabolic. And that's a really important concept. The second thing is consumption, which is what we measure with central venous oxygen, drawing a blood gas from the brown lumen, the distal port of a central line, and sending it to the blood gas lab or doing point of care ISTAT. Okay. This is representing I'm sorry, I don't know why that keeps going forward, is representing the amount of oxygen that the cells use. That changes every second. You wiggle your fingers, you use more oxygen. You turn to the side, you're using more oxygen. You cough, you use more oxygen. So it's changing every second, okay? But when your cells persistently increase their demand, they're hypermetabolic, you will actually release more hemoglobin from, you'll release more oxygen from your hemoglobin. That's called a shift to the right. Release from hemoglobin to dissolve in the blood to be used by the cell. If the cells don't need it, your SvO2 or ScvO2 will be normal or high, but the cells didn't really need it. And so that's called a shift to the left. That means oxygen is latched on to hemoglobin. So all we're thinking about is, are our cells using oxygen? We'll shift to the right. Are our cells not using oxygen? We'll shift to the left. So that's really important. Cells using oxygen, shift to the right. Cells not using oxygen doesn't necessarily mean they don't need it, but cells not using oxygen, shift to the left. That's what we talk about with oxyhemoglobin dissociation. Now, our desire is that any sick patient will, who has inadequate delivery or high demand, will always shift to the right. So the very first time we look at their ScvO2, it might be 45% or 35% or 20%. Now, you're going to write that down. You're immediately going to call someone. You're going to say, this patient is severely at risk for total body ischemia. And they say, why? His ScvO2 is 45%. And by the way, he has a base deficit of -10, which indicates a high metabolic acid. I have to do something about that. Okay, my doc says, I don't believe those numbers. All right, fine. That's okay. I mean, you gotta fight hard. You gotta advocate for your patient. Maybe you go above their head, or you go to your charge nurse, you go to your clinical specialist, you go to the attending, you go to the director, whatever you want to do, however you're comfortable. You're going to advocate for the patient, but also you're going to document notified physician of ScvO2 45% and base deficit -10. Now, for me, I'm a person that's been around a long time. I would probably write no orders associated with this information. Okay. Sometimes I see nurses write no orders received. Okay. Well, what does that tell you? It tells you that you were trying to bring that information, but I don't think you can stop there. You've got to advocate for your patient. This isn't a battle of the wills and the wits. This is a battle for someone's life. So I feel like you have to use a really good strategies to make sure that we're treating things that are important. So this is a little cartoon I use all the time. I drew a line in the center to say, okay, post-lung, blood goes to the left atria, to the left ventricle, out into the aorta, and out to the system. And that's where you measure PaO2, 80 to 100, SaO2, 95 to 100%. That's all pre-cell. So this all is telling me something wonderful, but it's only really telling me about the lungs. Now my cells use oxygen, and how I can evaluate what's happening at the cells is by looking at the blood in the venous bed, which is post-cell. It's also pre-lung, but post-cell. So I'll look at SvO2, 65 to 85. Remember, I'd like to see you right around 70, and your PVO2 around 40 to 50. We're not talking about a PA catheter here, so don't worry about that. You need to really be concerned about this. A lot of you are monitoring this, measuring it, drawing venous samples, and not doing anything with that data. And it's like, I can't believe we can get by drawing it, documenting we've drawn it, writing the number down, and then not doing anything. Really, really important. So again, remember delivery side dynamics, cardiac output, hemoglobin sat, that's all pre-cell. Your cells use oxygen, they consume oxygen, and then we look at what's left over. And the two compensatory mechanisms when you have problems, your patient himself will increase his oxygen delivery by increasing his heart rate and maybe increasing his stroke volume, can't increase his hemoglobin acutely, doesn't increase his SAT acutely. You have to pay attention to that rapid heart rate to say that's an increase in it's an attempt to increase cardiac output. And then the second and not very good compensatory mechanism is hemoglobin releases oxygen to dissolve in the blood and be used at the cell. So here's how I basically look at SvO2 or ScvO2. In a person that I have concerns about, maybe they have an elevated, a wide anion gap, they have a base deficit, they just aren't looking quite right, their pulses aren't really good, their fingers are cold, I draw an ScvO2. Now, in a compensated shock, your ScvO2 will be down because you're compensating by trying to deliver more and using more of your oxygen off your hemoglobin. So they may have a base that's normal to moderate in deficit. But that patient, if they're allowed to persist here in a compensated state, they are going to decompensate. So this is the best state to see when the ScvO2 is down mildly to moderately, and you might have a mild base deficit. Oh my God, I can pull you back now. I can give you volume, I can give you inotrope, I can give you red cells, I can give you sedation, I can keep you cool and try to get you balanced so that you're not at risk. But oftentimes, I'm sorry about that. I just wrote these slides, so sorry, there's a little 8 in there. In a decompensated shock, ScvO2 down, 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 and you now have a base deficit that's moderate to severe. So your base deficit might be -5, -8, maybe -10. You're decompensating, right? You now have really reached your limits and you are on the verge of total body infarct. Well, total body infarct is irreversible shock. Now, my cells can't use the oxygen because they've been shocked and they are dysfunctional. So ScvO2 looks normal, or it may even be elevated, but a normal to elevated ScvO2 in the face of a severe base deficit, that person is not going to survive. So this is very straightforward. This is not my drawing. This is the only thing that's mine. Okay. 75, and I would say 70, central venous gas. If you go down, that means your delivery is poor or your consumption is high. So you can see these are things I can treat. I can give you anti-anxiety or sedation. I can give you analgesia. I can cool you down. I can block your shivering. You're consuming a lot of oxygen. Let me treat those things. You're not delivering enough oxygen. I'm going to try to increase your cardiac output. I might also increase your cardiac output. I really can't help you increase your PaO2. Again, SaO2 of 88 to 90% is usually adequate. And then if you're on the higher side, so you're higher than 70 or 75%, you might be delivering too much. Maybe we are whipping your heart too much. We gave you too much volume and dobutamine, but I can't know if I'm giving you too much without looking at your base, your anion gap, your bicarb, your pH, whatever you want to use that tells you about the incidence of metabolic acid. And then when it gets much higher, frequently what you see here is when a patient has decreased their consumption, it's because blood is being shunted from artery to vein without passing through the capillaries. That can happen with really profound vasoconstrictors. It can happen when you have endothelial dysfunction, which is the primary alteration that occurs in late sepsis. So it's not just a number to be written down in your chart and just a pain in the neck that you've been asked to draw it. It is actually a directional signal to tell you what's happening. So when delivery is inadequate, always look to the tissues. You will shift to the right. Doesn't matter what kind of cardiac output you have. If oxyhemoglobin shifts to the right, that means ScvO2 less than 70, and for most clinical states, less than 65%. So let's say your patient has an ScvO2 of 50%. Their demand is high, and their cardiac output, even if it's 10, is poor relative to their tissue demand. Also, the content of oxygen might be low. That means they may not have adequate hemoglobin. So I'm always going to look at their cardiac output, their heart rate, their stroke volume, and their hemoglobin. You are at risk whenever you shift to the right because you now have dipped into the reservoir and you are utilizing oxygen from your reserve. And now if somebody comes in and turns you to your side, or your wife comes in and upsets you, or the neurosurgeon is kind of digging around, or the trauma surgeon is digging around, and all of a sudden you dip so profoundly into your reserve that you now are infarcting your cells. Okay, my friends, pay attention. to ScvO2. It's so incredibly important. Whenever you shift to the right, meaning ScvO2 is it always drops when you cough, when you turn, it should always return. But if it persistently stays down, cells are demanding or utilizing more of the oxygen you've dipped into your reserve, and the SvO2 is down, ScvO2 is down because you're releasing more oxygen in the dissolved state because the cells need it and they're using it. Now, if cells can use oxygen and the delivery is adequate, you may get a shift to the left, meaning you might be 70%, 75%, 78%, 80%. Don't ever see that number as being good without actually evaluating whether or not the patient has lactic acidosis or a base deficit, because this can fool you, right? You could have a patient who really needs that oxygen, but you've used so much vasopressor that they're shifting from the artery to the vein without any blood going through the capillaries, and they're not using oxygen. So shift to the left, you're above 70%, always requires that you look at least a base, a bicarb, and hopefully a lactic acid level. So that is a really important concept, my friends. It really helps us to appreciate and understand what it is we're trying to do. So when you see an ScvO2 that is normal to high, you always have to validate with an arterial gas or an anion gap on your chem. And that means now, not 10 hours ago. Now I'm looking at anion gap or serum bicarb, or what we call a Grady total serum CO2. Best to look at it with a gas. You could do an arterial gas, you could do a venous gas, it doesn't matter. You're drawing it from the venous sample, so just get the whole gas. Don't just get a venous oxyhemoglobin, get a venous gas. That'll give you your base deficit. You'll have an idea. So my ScvO2 is 74, but my base deficit -10. Brother, this patient is going to die. This patient is shunting his blood and not using oxygen. So that's a really important thing, because when delivery appears adequate, because ScvO2 seems normal, but the patient has acidosis, he's on vasopressors, he's on CRT, he's latching on to hemoglobin, but his cells can't utilize the oxygen that's been delivered. PaO2 is down, SvO2 is up, not utilizing oxygen. He's using the dissolved state, but he's not releasing his oxygen because his blood isn't flowing past the capillaries. Again, got to validate this with a blood gas, either arterial or venous, an anion gap, base deficit, lactic acid, blah, blah, blah. Always. Okay. So here is this patient. I'm sorry this is displaying because that was meant to dissolve in. This is a 78-year-old woman with history of hypertension, AFib, diabetes mellitus, COPD. She's presenting today with severe abdominal pain, and on exam, she's got diffuse severe tenderness throughout the abdomen. She's wheezing. You just looked at her vital signs: heart rate 110, respiratory rate 22, temp 37, 105/70. And 65% on her ScvO2. You might say, she's a little bit tachypnic and a little tachycardic, but I think she's probably okay. We'll look at her in an hour. But when we did a venous sample from a central line, her bicarb was 12, her lactate is 9, her base is in deficit at -8. That means she's got oxygen, but she isn't using it, which typically means she's vasoconstricted or she has some type of shunt. Okay, so now this, SvO2 45, SaO2 98, does that patient have enough oxygen delivery? Whenever your SvO2 is, or ScvO2 is less than 70, you never have enough oxygen. So you need to resuscitate this patient, resuscitate his consumption, pain, analgesia, sedation, make him cool, calm, and comfortable, and resuscitate his delivery. Volume, inotrope, red cells. It's always the same answer. That's all you have to remember. Okay. Over here, you're saying, oh, look, this patient looks pretty good. His SvO2 is 65 and his arterial sat is 98. Well, I think he looks okay. I'm going to report how great this is to my physician. However, you didn't have all your information. So here we are, SaO2 98, SvO2 45, base deficit -6. you're at risk, and you're at pretty significant risk. I better do something now. Treat your demand side, agitation, again, sedation, analgesia, keeping you cool, calm, and comfortable. Treat your delivery side, volume, red cells, cardiac output, oxygen carrying capacity. And here, this patient, SaO2 is 98, SvO2 is 65. He has a base deficit of -12. You are now all about trying to figure out why he has a base deficit of -12, because my friends, he will not survive if you don't do something now. Maybe he's one of those patients you have on 50 of norepinephrine because you've been chasing his blood pressure, which is not a bad thing, but the norepinephrine now is putting your patient at risk because you have an arterial venous shunt and your patient can't use his oxygen. So we increase delivery by improving stroke volume. You can do that with volume, inotrope, maybe mechanical circulatory support, something like an Impella or ECMO, and increasing oxygen content by increasing the total hemoglobin. Increasing the saturation of your hemoglobin above 90% does not yield much benefit, but you got to decrease his consumption, control his fever, control his work of breathing, make sure he's sedated, make sure you've controlled pain, make sure he's not seizing, make sure he's not shivering. And if he is, you might need to paralyze him so that he stops using so much oxygen, because he's going to kill himself because of his demand for oxygen. How do I use this? I use this as much as I can for almost every patient that I'm concerned about. For management and cardiac arrest, post-resuscitation, traumatic and hemorrhagic shock, severe heart failure, cardiogenic shock, sepsis, and septic shock. All the data, all of it, says that patients who don't, right during resuscitation, they always have a low ScvO2. Don't expect that they're not going to have that because you're doing inadequate compression, not because your compressions are poor, but it's just not the same as your heart. But if you don't get to 40% after return of spontaneous circulation, 100% mortality, even with blood pressure. Oh my God. 100% mortality if you don't have an ScvO2 of 40% after resuscitation. For trauma and hemorrhage patients who have vital signs that might be okay, those are pretty insensitive. Additional resuscitation or surgical procedures are required when ScvO2 stays less than 65%. So you gave some volume, you think things look good, the blood pressure is okay, you've got a vasopressor on board, you're all very happy, you go on to your next patient. Meanwhile, your patient is going to die. Pay attention. Pay attention. In a cold cardiogenic shock, sometimes we can have patients who have maybe they were hypertensive before, we don't know, and they have normal vital signs. They may have a relatively normal heart rate, a relatively normal respiratory rate, relatively normal blood pressure, but their ScvO2 is less than 40%. They're going to die. Okay, so how do I use ScvO2? To help me appreciate whether my resuscitation is adequate or not, and to guide me whether or not I need more resuscitation. Resuscitation in the face of cardiac output, which would be volume and inotrope, and oxygen carrying capacity, hemoglobin. So those are the only three things. Vasopressors resuscitate your vascular tone. They don't do anything about any of the others. And in fact, aggressive vasopressors actually typically make your base deficit worse. Pay attention. Pay attention. Stop titrating and thinking that's powerful when it could actually possibly, not always, but possibly be harmful. Pay attention, because as you titrate up, if your patient is responding, he may shunt his blood from artery to vein without releasing oxygen at the cellular level. And that means that his base will get worse. That's how I use ScvO2. Thank you so much for joining for today's Tuesday topic. Tomorrow, Wednesday, I'm going to try to run a simulation program. I might have to pre-record it, and we're going to hope that it's going to work. We're going to take a look at blood gases and how we're going to alter our ventilator and what's going to happen when we do it in a simulation program. I hope it won't be a big fail. I'm going to try from now on to stay close to 30 minutes. Thank you for joining today. Happy Halloween. Thank you very much. And I'm now going to stop my recording. So thank you. Bye-bye.